Patients with relapsed Hodgkin lymphoma really need to be evaluated on a patient-by-patient basis. Fortunately, we do still have curative options for patients that do relapse. The patient in this case, for example, relapsed a few years after completing their initial therapy, but was still in their mid-30s and otherwise a candidate for aggressive therapy. One of the considerations is to treat patients with an autologous stem cell transplant, which can be a curative approach in up to 50% of patients. And so if I have a patient that is otherwise young and does not have other comorbidities or other reasons not to proceed with transplant, I will frequently consider second-line chemotherapy with a regimen such as ICE, and then if they have a good response to therapy, proceed with autologous stem cell transplant. In some instances, for patients that have particularly high-risk features at relapse, we will do a stem cell transplant and then follow that with brentuximab vedotin as maintenance. And there's an FDA indication for those patients to use brentuximab vedotin. So that's something I often will also consider for patients either that relapse early or have extranodal disease at relapse or who may not have a complete remission going into their transplants. Patients may receive brentuximab vedotin for a variety of reasons in the relapse setting, and this is actually where it was first developed. Probably the most straightforward indication are for those patients who are not transplant eligible and who have relapsed, especially after receiving one salvage therapy prior to the brentuximab vedotin. The other indication that I often think about are patients who receive a stem cell transplant and who progress after the transplant. Those are two very straightforward areas where brentuximab vedotin is very effective. Fortunately, for patients with relapsed Hodgkin lymphoma, we now have a number of different approaches. So we've discussed potentially the role of stem cell transplant. We've also discussed the role of brentuximab vedotin, either in conjunction with a transplant or as a monotherapy. I also would point out that there are a number of brentuximab vedotin containing combinations that are also currently under investigation. One other class of agents, though, that is particularly exciting in this area are the PD-1 antibodies, nivolumab and pembrolizumab. And these are checkpoint inhibitors that stimulate the immune system and help it to attack the underlying Hodgkin lymphoma. And what we found is that roughly 2/3 of patients with relapsed Hodgkin lymphoma will respond to these PD-1 antibodies, and many of these responses can be quite durable. So this is another consideration, especially in a patient who may have underlying neuropathy or for whom I'm concerned that brentuximab vedotin may not be a good option. I would also point out that nivolumab is currently being investigated both in the frontline setting but also in the relapse setting in combination with brentuximab vedotin, and it may be that in the future these two agents are administered together for patients with relapse disease. Now that we have a number of very effective treatment options, and given the fact that we have started to move beyond standard ABVD, it brings up a lot of challenges with regards to what therapies patients should receive and when they should receive them. I typically address this with each individual patient based on their own risk factors and comorbidities. In a patient that ultimately chooses to receive ABVD as a PET-directed approach and achieves a complete remission, when they relapse, I often will try to get them to transplant, but if I can't or if they choose not to go to transplant, my first option for a relapse patient is typically brentuximab vedotin, and then if they progress off of brentuximab vedotin, I often will think about treating them with nivolumab. Again, this is still a very personal decision and based on the patient's individual risk factors. I'm very excited, though, about some of the clinical trials that are currently investigating this combination because I suspect that the combination may ultimately be more effective than either of these administered individually, but we'll have to wait for those studies to come out. One of the things that we found in this case is that we had a patient who was young, who was eligible for aggressive therapy, who achieved a complete remission but unfortunately still progressed. I think one of the areas of research that still is needed is to better identify those patients that are at high risk. We do have several laboratory and clinical factors that we can use that have been developed probably 15 to 20 years ago. But I think that there's more that we could do to understand the underlying biology of the disease to try to figure out who are those patients who may either need some additional consolidation or some additional treatment to try to prevent relapse. I'm also really excited to learn more about the role of combination therapies both in the upfront and relapse setting, and to hopefully one day have a better understanding of what is the optimal frontline regimen. As we discussed, there still is a lot of discussion regarding the most appropriate therapy for the standard advanced stage Hodgkin lymphoma patients, and I know there are additional studies that are being planned that may help us ultimately answer that question.